Buenos dias. Shalom. Ni hao. Ohio gozaimasu. Bonjour. Good morning, Downstate. Thank you for coming out to our 5th annual Dr. Martin Luther King Jr. Leadership Program Award. We're delighted to be hosting it for the 5th consecutive year. And at this time, we're going to start the program, so I will ask for Rabbi Holzman and Reverend Walker to give remarks and the invocation.
Good morning, everyone. Once again, it is a privilege to be here and especially to be with each of you at this, our 5th annual Dr. Martin Luther King Celebration and Leadership Award program. I believe sitting and standing together today, we each are testaments declaring that we will not allow Dr. King's legacy to perish and that together we will identify, understand, marshal what is needed and required to eliminate racial and ethnic disparities in health and in health care. It is really hard to believe that it was only 39 years that Dr. King walked this earth. It is an incredible feat in terms of his determination, his call for equality, equity, and justice. What he did produced an eternal legacy whereby we can have a better future and a wonderful generation. I am humbled, grateful, and empowered to continue to do my part with long-standing persistence in this community, in the communities of poverty, and through missions as part of a people on the incremental journey in fulfilling Dr. King's dream of achieving health, equity, equal care for every living person. That being said, shall we stand for the invocation? We're going to invite the presence of the sacred, the Lord, the Holy One, the magnificent benefactor, the God of many names, to be with us in our time together. Let us pray. God, who is full of peace, power, provision, and wisdom, as we gather together now to look back, to celebrate, to honor, and to mobilize, we welcome your holy and divine presence. Come now, rest upon every activity, every selection, and every heart. Open ears, ignite our passions for caring for one another, both in call and with fierce determination to eliminate, to prevent, and to serve in controlling diseases and illnesses, particularly among minorities and societies vulnerable and undeserved in ways guided only by you. Empower us in these moments with creative strategies and collective action, whereby we look to shape solutions and weather challenges that we will face. Embolden and infuse and rally our conscience to a higher vision and a moral mandate through our keynote speaker, Dr. Duffus, and our panelists, Dr. Taylor and Dr. Morton Rios and Dr. Banker and Dr. Elke, your champions of health equity. Please, Lord, allow us to hear you and allow us to hear from them. Allow us to own and declare, as does Dr. King, the fact that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Allow us to boldly note persistent and unequal treatment in our health systems, the black-white mortality gaps in heart disease, in treatments for cancer, diabetes, tuberculosis, kidney transplantation, infant, toddler, and senior deaths, mental illnesses, as well as caring and effective supports for persons living with HIV and AIDS. By your welcome presence right now, propel each of us to refuse to sit in the seat at the back of the bus of an unbalanced, unequal, and unfair healthcare system, and instead, O Lord, allow us to embrace the unfinished business of the civil rights movement, ultimately joining in the new frontier, the journey towards health equity, thus picking up where Dr. King left off. It's in your name that we pray. Amen. You may be seated.
Good morning. We celebrate today 87th birthday of a pioneer, but I would like to point out that SUNY Downstate is celebrating it this year right next to the Jewish holiday of Tu B'Shvat, the New Year of Trees. One of the main messages of this holiday is that mankind is compared to trees in order to learn a powerful spiritual lesson. The lesson is that just as a tree and always growing and alive and growing, just so should a man be always growing and expanding his activities and his and her potential. Martin Luther King Jr. is remembered for his championing the principles of equality among men and the importance of universal respect and brotherhood amongst all mankind. Despite the great gains that were made by Dr. King and the improvements in society that were made in the wake of his efforts, obviously the need for advancing those principles is similarly urgent in our times. I would like to suggest that just as we learn from a tree the importance of living our lives by continually improving ourselves and continually growing in our efforts, in our achievements, we should apply those principles to Martin Luther King Jr.'s legacy. We should rededicate ourselves to making efforts towards universal brotherhood, towards equality of all peoples, and towards mutual respect amongst all human beings. And at this time, let's remember, may I share with you the 7 commandments of God giving to all mankind, which is called the 7 Noah law: believe in one God who is infinite and supreme, respect the Creator, respect the human life, respect the institution of marriage, respect the right and property of others, respect God's creatures, and maintain justice. And God should give us and bless us all His blessing for the entire SUNY Downstate, and particularly for Esquire Kevin Antoine, and for Dr. Dorfis, and for the entire Downstate people and everyone that comes through these doors with all His blessings, that we should all have love and kindness, feeling all in brotherhood. Thank you.
Let me say right out, Dr. Williams, our president, was called out to a urgent meeting, so he won't be able to join us today to give greetings, but he said if the meeting ends early enough, he will come in later. So what I told him was that allows me and the Vice Chancellor a longer time to speak. Every year I start off by reminiscing a little bit about how I grew up in Mississippi and how the Civil Rights Movement, my family was part of it down there, what my mother and father did. And so today I wanted to start out with a brief little story, and because you never know how your timeline affects you. We all think that that things are unset, that we don't know what we're put on earth here to do, and things just sort of happen. But when you get old enough and you're able to go back and look at your timeline and you see how things have dropped in your timeline, you sort of get a glimpse. If you don't know for certain, at least, you sort of get a glimpse of the things that you're supposed to be doing, or that track that you're supposed to be on. So let me just share this story with you. Of course, you know, we're a military family. My dad was in the Army and Air Force, in the Army during World War II, and then later on switched over to the Air Force. He was, at the end of World War II, he went back to college at Alcorn A&M in Mississippi to play football. Now that football team had a lot of people that would become famous during the Civil Rights Movement later on. Both Charles and Medgar Evers were on the football team. And you don't know him too much here, but a guy by the name of Aaron Henry, who was a big pioneer in Mississippi in civil rights, was on that football team. But anyway, in my dad's last assignment, we basically grew up on the air bases of Japan and upstate New York. And in the last years of his career, he decided that he would retire back in Mississippi, where he was from. He said that all of his kids, we were too high-strung to go live in a big city because we had no knowledge of segregation. We lived in Japan for a long time. He was part of the occupying force after World War II, and we stayed there a long time. So we moved back to Mississippi, and my older brothers, I talk a lot about my second oldest brother, Greg. That was the one my dad, with my other siblings, sent up to the high school to integrate it. But before he did that, when we were still going to the all-segregated elementary school, Greg was kind of a daredevil. He's always in trouble. He spent an equal amount of time in the principal's office at the black school as he did at the principal's office when he integrated the school at the white school. He's just one of those kind of guys. But one day, a neighbor's house caught on fire. And we don't know today if the reason for the fire department was not to go into the house to rescue the lady. It was a good friend of my mother's, because the fire was just too out of control and it wasn't worth the risk of going in there, or because it was on the other side of the tracks. We don't know today what the reason was, why they didn't go in to rescue her. But my brother Greg did. He was 15 years old. He kicked in the door, went in and brought Miss Creola out and set her on the steps. She eventually died 2 days later from smoke inhalation and all the burns that she had on her body. But my dad took my brother to the closest hospital he could take him to at that time, was Gulfport Memorial Hospital. We didn't have any black hospitals in Mississippi, but we had segregation within the hospitals that was there. And my dad was still in the service at the time. So he's a master sergeant. He walks his son into the hospital. He tells him what's going on. And he said for 20 minutes, my brother just laid on the cot, coughing. No one came to see him. No one came to ask anything. So he finally, and we say thank God for the military base, he picked him up, put him in the car, drove another 20 miles to the Air Force Base where we lived at, and brought him to the hospital there, and they treated him right away. I say that to say now because I look at my timeline. These are the things that we're talking about today. This is the kind of work that I'm engaged in today. So that incident, to me, just didn't happen by happenstance. That's part of my timeline. I'm able to reflect back on that from a personal standpoint to see that in 2016, there are still some things that were going on in the prior century that are unresolved. And one of the things that I think that as we move toward remedies with unequal health in America and health disparities is that we look for other models. One of the things that I always admired about what President Kennedy used to say, I'm not young enough to remember him a lot, but when I go back and read, is that there can't be an American solution for all the ills of the world. Some countries are just not ready for the things that we are doing. And in the same sense, we don't have all the answers. So I think that as we start looking at things that the World Health Organization talks about, the social determinants of health, things that affect people in their everyday lives, where they live, what kind of transportation they have, what food do they have access to, how they age. If those things are important with respect to contributing to the kind of health that they're in, then those are the things that we should also be looking at when we're trying to come up with solutions to their healthcare problems. These are the things that the World Health Organization deems very relevant when we're looking at the clinical diagnosis and prognosis of how we take care of our patients here. And with the changing demographics in the United States, it is projected in recent years, in about 40, 45 years, that the current underrepresented populations will be the majority populations. But that's not trickling over into the healthcare workforce. So what that calls for is a greater effort at the healthcare workforce to start mirroring the population that is going to be taken care of. That's not to say that we don't have those numbers in our general population, but we don't have them in our healthcare workforce right now. So I think these are the things that lie ahead that we have to continue to work on. We're doing some of that training here at Downstate. We have the Brooklyn's Health Disparities Department. We have a lot of professors engaged in this kind of work. Even here at Downstate, our office partners with University Hospital of Brooklyn to do the cultural competency training. But that needs to continue across the United States. Because what we're going to have if we don't continue to do this, I'm fine. If we don't continue to do this, we'll have a population not trained in providing cultural sensitive health care to a population that desperately needs it. So at this time, I am glad to introduce a good friend of mine who's going to bring greetings from SUNY Systems. Dr. Carlos Medina is the Vice Chancellor for the Office of Equity, Inclusion, and Diversity at the systems level. Dr. Medina is a good friend of mine. He's recently elected to the Board of Trustees of the National Association of Diversity Officers. He's one of the, at the national level, he is the only Chief Diversity Officer over a state system at the national level. And so we're glad that it is in New York State that he's here and that we have him here. So at this time, I'll ask Dr. Carlos Medina to come up, the Vice Chancellor for SUNY Systems.
Good morning, everyone. Good morning. Buenos dias. I'm not sure that I can say it in as many languages as Kevin did earlier, so I'm going to stop there. But, you know, it's really a pleasure for me to be here this morning. I came from Albany, but let me say I was born in Kings County Hospital, and I'm very proud of that. And I grew up in Williamsburg, Brooklyn, in the 1960s. And every time that I tell someone that I'm from Williamsburg, Brooklyn, they say, "Have you been there lately?" Well, yes, I have. And I can tell you firsthand that the Williamsburg, Brooklyn of today, it is not the Williamsburg, Brooklyn of the 60s where I grew up. And so I don't think you could even sell homes back in the 60s. Nobody wanted to buy it in Williamsburg, Brooklyn. But today, if you choose to live in that community, there's a serious question about affordability, right? Because it's just so incredibly expensive. So it's nice to be in Brooklyn, okay? So I want to just take a second, and I'm hoping that you'll join me in applauding Kevin because he's really doing some great work. So thank you for all the diversity work and inclusion work that you do right down here in Downstate. So I am truly honored to be here today in celebration of Dr. Martin Luther King Jr. and his legacy. And so on behalf of Chairman H. Carl McCall, Chancellor Nancy Zimpher, and all of SUNY, once again, welcome. In honoring Martin Luther King, it is important to recognize how civic engagement and community service have contributed to the progress we have made relative to civil rights and tolerance throughout our communities, our state, and nationally. It has been over 50 years since King's supporters gathered at the March on Washington, where the resonance of King's voice and message created a spirit of possibility, acting on a dream for equality. And yet, I'm reminded that while we celebrate Dr. King's legacy, in my heart, I feel that in some ways, his dream has not been fully realized. We need to continue to encourage people from all walks of life to come together to solve our most pressing national issues, two of which are education and, of course, health disparities for our most underserved populations. SUNY, the State University of New York, continues to acknowledge the importance of diversity. For example, as a chancellor's initiative and charge, the university has recently adopted a sweeping diversity, equity, and inclusion policy that will help SUNY become the most inclusive system of higher education in the country by ensuring more diverse representation and equity for students, faculty, and staff throughout the entire system. And for those of you who may not be as knowledgeable about SUNY, I doubt it, I think everybody here is, we are the largest comprehensive system of higher education in the country. We have 64 campuses, almost 90,000 employees, and 500,000 students. That is really saying something. And so I'm also pleased to mention one more time that Kevin Antoine was one of the highly talented committee members on our task force that helped create the policy that I just referred to. Not only are we evaluating how far we have come in terms of access and inclusion, we are pressing forward by recommending actions that will help transform the university's culture and the way diversity initiatives are viewed throughout the system. Here at Downstate Medical, you are in the midst of one of New York City's most diverse communities. The civil rights of one group also impacts all the others, whether we are providing equity for employment, programs for professional development, or cross-cultural competencies for patient care. Downstate recognizes this challenge and has led many educational programs to build cultural competencies through healthcare education initiatives. It is as though Dr. King's resounding question, "What are you doing for others?" is in the hearts of everyone who serves this community out of this institution. In closing, let me say that as SUNY's Chief Diversity Officer, I'm very passionate and fully committed to advancing diversity and inclusive excellence throughout the university, as well as doing all I can to hold it accountable. For it is a critical part of the mission, all the way back to 1948 when SUNY was created. So as we all look to make the world a better place, I leave you with the words of Dr. King, who once said, "If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving forward." And we are. Thank you.
I want to again thank Dr. Medina for those words of inspiration and hope. And, he mentioned, some of the things that I'm involved in, but I can't take all the credit for that because I have a great staff that steers me, where I need to be. And part of that staff includes Shondell Goldsmith, who's the real lawyer in the office. Lorraine Brooks, who recently retired but was instrumental in providing all the employee assistance program services here for Downstate. And right before I bring up AVP Mike Carrell to bring up the Assistant Borough President, I want to just acknowledge all the officers that have helped us to prepare for the day's program. That includes the Office of the President. That includes Biomed, the biomedicine people that helps us with the filming and the pictures and the posters that you see out here. That includes library services that helps with the on-screen images that you see and the audio that you see. And we also want to thank all the academic colleges that have loaned us their professors that make up such an extraordinary panel that you're going to hear from later on. And I also just want to give a quick shout out to Dr. Duffus from the CDC. With all the things going on in the world right now, with all the new diseases that come out every day, I mean, it's just, I am humbled, to have him accept our offer to come up here and speak at Downstate and to sort of put us, hopefully, maybe, in the mix of some of the things that are going on down there. So I really want to thank Dr. Wayne Duffus for accepting our invitation. So at this time, I'll call up our Assistant Vice President for Government Affairs and Community Engagement.
Good morning, everyone. We are very privileged today to have with us the Deputy Borough President, Diana Reyna, who will give us some brief remarks on Martin Luther King Day and what his leadership meant. But in listening to everyone, I took away a deeper message from Kevin and from the Dr. Medina, and it's that we have come far, but we have a long way to go. I personally have been through a war, a personal war, and a lot of us who have come through the 60s and 70s have experienced a war, and that war was the war on poverty. And I'm gonna tell you something, I'm still working out my PTSD, every day, because there's, as I said, a lot of things have changed, but a lot of things still need to be reshaped and changed, and changed in terms of the system that we're dealing with. But I'm not gonna go much further with that, because I see everybody saying like, oh, well, he's getting ready to get a little Malcolmized here. But let me say that we are very fortunate to have the Deputy Borough President here, and I want to give you a little bit of background on her. Deputy Borough President Diana Reyna has spent 12 years on the New York City Council. She is presently the Deputy Borough President, and she has been in that office since 2014. And a little bit more background about her. As the first woman of Dominican descent elected to the office of in New York State, she focuses on ways that she can advance and advocate for over 2.6 million residents of New York City's most diverse borough. Reyna supports innovation and high-tech job creation, investing in women or minority-owned businesses, as well as businesses, incubators that facilitate the critical work of entrepreneurs in creating startup companies. She focuses on knocking down barriers in the path of women and men who are hoping to take a chance and follow a dream. Daily, Reyna envisions new and bold ways to tackle Brooklyn's inequities. She is a tireless advocate for the BQ Green Project, which will deck the part of Brooklyn Queens Expressway that bisects the south side of Williamsburg, as was mentioned by Dr. Medina, with a park that bridges the community and improves the open space ration, bolster local businesses, and improve quality of life in northern Brooklyn for thousands of residents. Reyna believes that Brooklyn has many great success stories and is at the forefront of culture, education, and the arts and diversity. She says that Brooklyn has become a terrific global brand, but it is so much more than that. Brooklyn holds our future, our children, our neighbors, our artists, our entrepreneurs, our schools, and our businesses. And she is inspired and excited to champion the causes of Brooklyn. So, that said, what it means is that she is a dynamic legislator, and she also does a mean merengue. But without further ado, I'd like to bring to the podium Deputy Borough President Diana Reyna.
Good morning to everyone. Good morning. I'll spare you a merengue today. My name is Diana Reyna, and I am the Deputy Borough President alongside serving Brooklyn for you with our Borough President, Eric L. Adams, and he sends his greetings. We are proud to serve 2.6 million people, a dynamic borough of what is 46% of families who speak a language other than English at home. That is a remarkable gesture of who we are today versus the days of Martin Luther King Jr. As I stand here before you, I would be remiss not to give greetings to Dr. Williams, although he is not here today, President Williams. We want to make sure that we are able to lend support wherever possible as I look around the room, just making sure that we continue to press upon you that you are not alone as SUNY Downstate. Borough President Adams and I constantly on the phone with SUNY, Mr. McCall, who has the opportunities to make sure that our only medical institution in Brooklyn remains open. And that is the legacy that speaks true to what Dr. King's message was to all of us. And it is all of our job to maintain that message. I want to just remind us that when we talk about SUNY Downstate, we shouldn't forget the history that this great institution is responsible for. This is the home of where the first MRI, correct me if I'm wrong, was invented. That story isn't told. For what reason, I don't know. That film, that documentary, that book should include those historical timelines. Nobel Peace Prize winners came out of this institution. Those are the stories of the men and women we should be talking about, that are relative today as they were in their time. This is the home of where Viagra was invented. And if no one knows the brand, then they're dead. Where are the royalty fees to this institution to keep it resilient as the only medical institution in Brooklyn? Royalty fees, let us learn from Shark Tank, are the way to live. And this institution deserves those royalty fees from so many making millions and billions of dollars on the invention of that one small pill out of this institution. Let us not forget, after today, we must demand royalty fees for this institution, for every intellectual property it develops from here on then. That is the message of today. I say that with no reservation. I am unapologetic, coming from Williamsburg, Dr. Medina. Born and raised, parents who came from the Dominican Republic here, in a time when it was tumultuous to come here, but even more so in the Dominican Republic under a dictatorship from my mother, single, in her 30s. To be able to come here and understand no English, but survive and understanding that she had freedom, that she can fight a better life here than back home, not just for herself, but for her 8 brothers and sisters and her mother, who was raising all of them alone, after having lost her dad when she was only 12 years old. And so it is important that we all understand Dr. King's message. Dr. King called for equity. Equity for all when it comes to health, education, justice, human rights, and welfare. Without it, our experiment called the United States would fail. People across the United States have honored Dr. Martin Luther King Jr., but let's not forget the journey and legacy. To me, Dr. King represents a journey of great importance and significance that we have inherited and strive for each and every day. We know that Dr. King's dream is unfinished. His legacy is what we try to live up to. I am not afraid are the words he used. I too am not afraid. Are you? Can you stand before each other and say you are not afraid? I will not be satisfied are the words that he continuously expressed. I am not satisfied until we see a better Brooklyn. Are you satisfied? We cannot be satisfied. We cannot be afraid. Today, as we reflect on the road ahead of us, I am reflecting on his words. We must learn to live together as brothers and sisters, or we are going to perish together. We live in challenging times as a city. We are surrounded by beautiful diversity in Brooklyn, where 47% of us speak a language other than English at home. In Martin Luther King Jr.'s name, We must remember our core values as Americans and as decent human beings. We are a nation of diversity, the sum of peoples from all over the world. Let us be king-like and embrace who we are. Dr. King knew that our diversity is our strength. That continues to be more so today than ever before. Let us embrace who we all are in the year ahead. Embrace the diversity we share. The 2016 recipient of Downstate Medical Center's Dr. Martin Luther King Jr. Leadership Award is the CDC's Office of Health Equity's National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. Dr. Wayne Duffus, Associate Director of Health Equity and Director of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention, who will accept this award and give his keynote address. Dr. Duffus, I'd like to present to you this citation on behalf of Borough President Eric L. Adams and myself. And I'd like to read, whereas it is a time-honored Brooklyn tradition to recognize those individuals and organizations which demonstrate an outstanding commitment to promoting excellence and provide outstanding services and support to local residents and those in need in the healthcare field, it is therefore fitting that we join together in acknowledgement of their special events and occasions. Whereas on behalf of all Brooklynites, joining today with medical professionals, supporters, and friends of SUNY Downstate Medical Center to recognize and honor Dr. Wayne A. Duffus for his dedication and outstanding contributions to ensuring that the borough of Brooklyn has healthy communities, placing the patient, the person, first. Whereas on behalf of all Brooklynites, we salute Dr. Duffus, a graduate of the Albert Einstein College of Medicine with an MD and PhD in virology, now you're gonna help me, virology, cell biology, and Associate Director of Health Equity at CDC's National Center for HIV, Viral Hepatitis, STD, and TB Prevention, for his exemplary leadership role in promoting health equity across the National Center for HIV, Viral Hepatitis, STD, and TB Prevention by increasing collaboration and advancing scientific agenda across the center. I applaud him for his previous service as a CDC EIS officer from 2002 to 2004 in Columbia, South Carolina. I commend him for publishing 70 professional papers and being involved in numerous public health projects. I appreciate Wayne Duffus, MD, for making a positive impact in the lives of others, and I thank him for all that he has done to touch and improve the lives of many while helping to move and shape our communities forward as one Brooklyn, as Dr. King's legacy. Now therefore, Eric L. Adams do hereby confers this citation upon you, Dr. Duffus. Please accept this award. Please come and join.
We want to thank the Borough President for that very inspirational message. So at this time, we're going to show a short film on health equity, and then we will have the panel come up and start our health equity panel. At the end of World War II, when the United States emerged as the lone superpower, we were the craftsmen behind organizing the United Nations, the World Health Organization, and writing such influential international treaties as the Universal Declaration of Human Rights and the Constitution for the World Health Organization. And in all of these international treaties, they all say that there is a international right to health care. Now, this was 60 years ago.
Wow.
And each nation then was to implement the right to health care based upon these international treaties that they signed. Well, all of the major powers in Western Europe that took part and were the original signers of that, they've done that. The lone holdout has been the United States.
And what they do in England is entirely different. In England, the entire cost of medicine for people of all ages, all of it, doctors, the choice of doctors, hospitals, from the time you're born to the time you die, are included in a government program. The fact of the matter is that what we are now talking about doing, most of the countries of Europe did years ago. The British did it 30 years ago. We are behind every country pretty nearly in Europe in this matter of medical care for our citizens. And then those who say that this should be left to private efforts. In those hospitals where the doctors said they wouldn't treat anyone, who paid their hospital bills through Social Security, those hospitals and every other new hospital, the American people, all of us, contribute 1/2, 1 or 2/3 for every new hospital in the national government. We pay 55% of all the research done. We are concerned with the progress of this country.
Whatever affects one directly affects all indirectly. For some strange reason, I can never be what I ought to be until you are what you ought to be. The rich man can never be what he ought to be until the poor man is what he ought to be. John Donne caught it years ago and placed it in graphic terms. No man is an island entire of itself. Every man is a piece of the continent, a part of the main. And then he goes on toward the end to say, any man's death diminishes me because I am involved in mankind. Therefore never sin to know for whom the bell tolls. It tolls for thee.
So at this time, the panel members will start.
Introducing the 5th Annual Downstate Medical Center, Dr. Martin Luther King Jr. Leadership Award Program Health Equity Panel of Healthcare Professionals. Ian Taylor is the Emeritus Senior Vice President for Biomedical Education and Research and Dean Emeritus of the College of Medicine at SUNY Downstate Medical Center. He is currently a tenured professor in the Department of Medicine. Dr. Taylor has a distinguished record of accomplishment in medical education, patient care, research, and academic administration at the senior level. He is a recent past president of the American Gastroenterological Association. Dr. Taylor earned his PhD in physiology and his medical degree from the Liverpool Medical School in England. Professor Karen Benker is Associate Dean of the School of Public Health at Downstate Medical Center. Dr. Benker's work centers around improving the adaptation of health and social services to the public health and healthcare needs of urban and immigrant populations. Professor Benker earned her medical degree from the University of Southern California and a Master's of Public Health from Columbia University. Wayne Duffus is the Associate Director for Health Equity at the Centers for Disease Control's National Center for HIV, viral hepatitis, STD, and TB prevention, NCH-HSTP. In this role, Dr. Duffus is responsible for promoting health equity efforts across NCH-HSTP by increasing collaboration and advancing the scientific agenda across the center. Dr. Duffus earned his medical degree from the Albert Einstein College of Medicine and a PhD in virology and cell biology from the Albert Einstein College of Medicine. Dr. Dawn Morton-Reyes is President and CEO of the National Commission on Certification of Physician's Assistants, NCCPA. She is the first physician assistant president and CEO of the NCCPA. Dr. Morton-Reyes served as Dean of the College of Health-Related Professions and a professor at SUNY Downstate Medical Center. Dr. Morton-Reyes' expertise is in health professions education and centers on curricula innovation, promotion of diversity and educational access, and institutional and student assessment. She earned her physician assistant certificate from Howard University and her doctorate in education from St. John's University. Daniel Elke is an assistant professor of health policy and management at the School of Public Health at Downstate Medical Center. His research focus is on student reform episodes in the American and British healthcare systems, most notably the Affordable Care Act. Professor Elke earned his PhD in political science from Brown University. The moderator for today's panel is Shondell Moore Goldsmith. Shondell Moore Goldsmith is the Director of the Office of Diversity and Inclusion. Ms. Goldsmith consults with Downstate's leadership and administration on all matters concerning compliance with federal, state, and SUNY policies that prohibit discrimination in employment and education. Ms. Goldsmith previously practiced law in the litigation department of several New York law firms, including Milbank, Tweed, Hadley, and McCloy, LLP, and Paul, Weiss, Rifkind, Wharton, and Garrison, LLP, where she worked on government investigations and litigation, including securities and bankruptcy filings. Please welcome our panel and moderator on the topic of health equity, the new frontier in civil rights.
Good morning, everyone. How are we doing? Enjoying the panel so far? Enjoying the event so far? Good. So first and foremost, I would like to welcome our panel members. We're very happy to have such a distinguished group of individuals to speak on this issue. So I want to get right into it. The issue of health equity, as we know, is not a new one. In 1985, Margaret Heckler, who was the Secretary of the Department of Health and Human Services, commissioned a report. This report, called the Secretary's Report on Black and Minority Health, also known as the Heckler Report, was a report that was produced by the federal government and first acknowledged that eliminating health disparities should be a national priority. The report spoke to the significant differences in the prevalence of disease and higher mortality rates among African Americans and other racial and minority groups. Specifically, it noted that there were significant disparities between non-Hispanic whites and racial and ethnic minorities in the United States. Secretary Heckler spoke about what she called the sad and significant fact of a continuing disparity in the burden and illness experienced by minorities. This leads me into my first question, which I will direct to you, Dr. Taylor. It's been a little bit over 30 years since the Heckler Report was first issued, and we still have these issues of health disparities. It's still a very relevant issue. My question to you is, what would Dr. King think about the current status of the United States healthcare system, especially as it relates to vulnerable and underserved populations?
Well, speaking for Dr. King, I'm worried about doing that, but since he's one of my heroes, but I think he would be pleased to see the Affordable Care Act passed. I think he'd be particularly pleased that it was championed by our first African American president. Having said that, I think he would be disappointed at the lack of progress in terms of access to quality care for most minority populations. I think he'd be extremely displeased with the healthcare disparities that the American healthcare system is still plagued with. He would find it unacceptable that minorities still die prematurely of preventable disease. So while there might be some things that he sees that we've made progress on, I think largely he'd be disappointed with our current healthcare system. I think he also might see it as a bellwether for the social problems that we still see, and we particularly see here in Brooklyn. There is a direct correlation between poor healthcare outcomes and poverty, and we're all aware that poverty disproportionately affects women and minorities. Direct correlation with poor housing, poor schools, and lack of job opportunities. So all of those things feed into the problems within our healthcare system, and it's a much larger problem than just the healthcare system itself.
Thank you, Dr. Taylor. Dr. Morton-Reyes, can I ask you to just give us your thoughts on the progress we've made so far in terms of healthcare and disparities?
I think to echo Dr. Taylor's remarks is fitting. You know, I think we've made significant inroads in the recruitment and retention and graduation of diverse health professional students and the integration of the healthcare landscape, but there's so much more to be done. I think we've made significant progress in addressing medical problems and medical concerns. I think the implementation of the Affordable Care Act certainly has made healthcare more accessible to the populace, but there's still much more to be done. You know, the systems are large and complex, and there are many competing variables that play or press upon the healthcare system and the delivery of care at the grassroots level. And so I think to the extent that we as individuals take on the responsibility to do what we can where we are in the ways that we can to affect change, the responsibility resting with us, that in and of itself provides, I think, a light, a beacon of hope for the future. If we're waiting for a system to fix the overarching problems alone, I think we'll struggle, continue to struggle. So yes, there have been significant progresses made and advancements made, but there's still much more to be done as it relates to making health professions and health care accessible to the larger population.
Thank you. Dr. Banker, speaking of systems addressing our healthcare needs, the United States is often compared to other industrialized nations that sometimes subsidize care. Canada, Great Britain, Germany. My question to you would be, when we talk about health equity, can equal access to health care, do you think that would ensure health equity? So everyone has equal access to health care. Are we now in a situation where health equity is no longer an issue?
Yes, that's a very important question. We have a long way to go before we have equal access to health care, but the reality is that even if everyone under the age of 65 had very good health care in this country, it would prevent only about 15% of premature mortality in that group, because health is determined much more by the social determinants. By the time people get sick, some of that those deaths are just unpreventable by then. We have to deal with people having a house to live in, having a secure income, having safe streets, a good education. It's only when those social determinants are taken care of that the full impact of healthcare can take place. And so that struggle, and I sort of see this a room of warriors here, right? Ready to fight for health equity. Part of that means addressing the social determinants of health so that healthcare can really have its full effect.
Thank you. Dr. Elke, let me ask you, one area that we have made progress is with the Affordable Care Act. Tell me about how you feel about the progress we've made since it was enacted in 2010.
Well, I think I'm going to be echoing some of our other panelists in that the takeaway message, I think, is that we've made significant progress, but we have a significant ways to go. Too often in this country, we reduce health reform and change in our health care to what is really health insurance reform. And one of the chief goals of the Affordable Care Act was to widen insurance coverage either through public provision under such programs as Medicaid or under private provision on the state insurance marketplaces. And on that count, we've been quite successful. The estimates vary considerably, but anywhere from 9-10 million perhaps now are newly insured as a result of the Affordable Care Act. And that's real progress, and we can cheer that. However, it's important to remember that access to health insurance certainly does not equal access to the healthcare system, especially when we consider the fact that, thank you, that too many insurance plans are so-called narrow network, have very few physicians involved in them, and too many communities have too few physicians and other health professionals practicing on the ground at all. And as long as that's the case, we may see an uptick, continued uptick, in the number of people who are insured, but we're not necessarily going to see quite as significant an increase in the number of people who actually have access to our healthcare system, and that is vitally important.
Dr. Duffus, your office is working nationally. You're with the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention. Tell me a little bit about what your office looks for in a program that would effectively handle health disparities. So what are some of the essential elements of an effective program?
Okay, thanks for your question. So I think there are several parts, and the first should be that it should be based on science. We should pursue science. We should look at the epidemiologic data to tell us where we should put our resources. Oftentimes you have to choose between giving one jurisdiction funding versus the other, and you can justify it by looking at the science and what the data says. I think it's also important to have a comprehensive and multi-tiered approach. Tom Frieden's health impact pyramid shows that interventions at the base of the pyramid affects many people, but requires less effort. And when you get to the peak of the pyramid, it requires more individual effort, but fewer people. But you need interventions all along the pyramid in order for it to be very effective. I think it's important to disseminate information internally and externally. Oftentimes we go into communities and we do research, and we never go and give feedback, and they have no idea what happened to the research. And so next time, when we go back and ask for assistance, the answer is no. I don't know what you did and what you did with the data. I think it's important to include investments in programs and interventions that have been shown to be effective, not just efficacious. We need to stop the unfunded mandates, where you're told to do this, told to do that, but there is no money and there's no staff, no human resources whatsoever, and you're supposed to get it done. In addition to that, about 70 to 80% of health outcomes has nothing seemingly to do with health. So it means that we should collaborate across multi-sector. So this is a hospital system, but then transportation, the criminal justice system, Department of Education, all those other institutional representatives need to be at the table in order for them to understand and for us to talk in the same language. I think it's important to build community capacity and improve partnership. The community has to own the problem. We have to stop being paternalistic or maternalistic and tell them what they need to do. We're not very good at telling them how to do it. They know how to do it. They need to be a part of decision making. And our surveillance systems, we need to improve our data collection. You can't measure something that you're not collecting, and what's measured gets fixed. So you have to be asking the right questions. And finally, I think it's important to expand support for racial and ethnic minority individuals who will go back to their community and work, as well as non-racial ethnic minority individuals who are interested in working in that population. Oftentimes in resource-poor settings, the programs are based on one sole individual. So when that individual departs, the program disappears. And so that has to be a strong consideration. So those 7 points that I've just outlined, I think, are considerations, essential components for a health disparity program.
Dr. Banker, when we're discussing issues of health disparity, sometimes people hear health disparity, equity issues, they immediately start thinking about race, but we know there are many different factors. There's where you live, work, your educational status, immigrant status. I want to ask you a question about how does an issue such as homelessness relate to health equity?
Right. Well, I think the simple answer is no home, no health, right? That in New York City right now, we have about 60,000 homeless people, which is more than most zip codes have. But you can imagine what it's like and 40% of those are women with children. And you can imagine what it's like to finally your aunt said, well, I'm sorry, you can't stay here anymore. You know, the landlord says you have to go. And you probably have one suitcase with wheels and then maybe a couple of canvas bags and a grocery cart, and you go to apply to the city for a shelter. And those shelters are really, really bad. I visited one where the mother found a dead rat in the oven. I talked to a mother recently who is from Brooklyn, put in a pretty decent looking shelter in the Bronx, but every morning at 5 o'clock she got up with her kids to bring them back to their elementary school here in Brooklyn because the school had a link to Medgar Evers, and she wanted to make sure that they would get into Medgar. It's an impossible strain. So with those kinds of, and you probably saw the paper today that a man was knifed to death in the men's shelters, one of the men. So people who are homeless simply, even if they have access to health care, have so many other things going on in their life that the death rate in that group and the hospitalization rate in that group is just skyrocketing. And unless we, again, create programs where people actually have a safe place to live, then we can start addressing their healthcare needs effectively. But right now, we see a growth in the number of homeless people and a real scramble to figure out how to deal with that. So it's a challenge, I think, that the city is going to have to face with a lot more vigor.
Speaking of challenges, Dr. Morton Reyes, can you talk to us about what our educational institutions and programs can do to help promote a more diverse healthcare workforce?
You know, when I think of health equity, I think of not only having access to care through insurance, but also having health providers and service providers across the spectrum that can relate with the patient. Let's be clear that if I deliver information to you or I give you a recommendation and you can't relate to me for whatever reason, because perhaps we don't speak the same language or you don't get the feeling from me as a patient that I care about you, everything that I say and all of the recommendations that go along with that treatment and management plan that clinicians are educated to provide goes out the window. So I think educational programs have the opportunity and perhaps the obligation to think of recruitment and retention of diverse students as not only a good thing to do, a vital thing to do when you look at the demographics of America and what's projected going forward. Our workforce must reflect not only racial and ethnic, the populace in that regard, but also spiritually and psychologically and economically. People who can tell a story to a patient so that the patient can relate to it. Mm-hmm. We heard even this morning several stories of people's experience, and when those stories are told to others, they make a difference. So I think educational institutions have an opportunity and an obligation to look at their admission criteria, to look at their recruitment and retention strategies. Where are you looking for your students? What are you valuing in the admissions process? If you're only valuing or primarily valuing the grade point average and the test scores, you have narrowed your pool, your population. And I've spent the best part of my career in health professions education, so I certainly appreciate the requirement for a solid academic foundation. These are not easy curricula, so you have to be smart and you have to be capable. But what's the threshold? Do you have to have a 4.0 fill your class from the top down? Or is there a threshold of success as demonstrated by review of the data? How have your students done that have enrolled with a 3.4 GPA? Have they been successful? And I think the evidence suggests, and the AAMC has a wealth of data on this, as well as in the other health professions, that there is a minimal threshold of knowledge and skills as measured by the standard indicators that suggest that a student will be successful, or that students in general will be successful if supported, if they're not in a hostile environment, if the institution it really takes seriously its commitment to diversity, its commitment to a holistic admissions process, and has a curriculum in place and faculty that subscribe to that school of thought. It's not a singular entity. Enrollment without retention strategies is like recognizing a student at risk with no interventions is like identifying a diagnosis or making a diagnosis, identifying a problem, and not offering a treatment plan, and then wondering why the outcome is poor. So I think the educational institutions have a real opportunity and an obligation to look holistically at their admissions process, their recruitment and retention of students and faculty, promotion and tenure across the board for faculty as well, because the whole initiative of recruiting and retaining diverse students cannot rest on one or two diverse faculty. I asked the institution the challenge, what does the leadership at the highest level of the institution believe in? And what they believe in will be demonstrated in what they support. And initiatives that support at every pivotal point the recruitment and retention of diverse students have significant outcomes in that regard. It's really very, very simple when you unbundle it and look at it at every point of the educational process. And having experiences that get students out into the clinics, out into the community, and know the value of providing service. I recently saw where several universities are now valuing, and the Ivy Leagues included in their undergraduate admissions requirements, are valuing community service as part of their admission criteria. That's a shift. That says that there's something else that makes a good educated provider, not just your science acumen, but also your compassion and your commitment to others.
Thank you. Dr. Taylor, let me ask you, from the perspective of having students here and training, how are we doing in terms of training and having our training be something that can be used to create an understanding of the importance of diversity? So how do we address that?
I think one of the things I was most proud of when I was Dean of the Medical School here at Downstate was that we became a minority majority during my tenure as Dean. Other than the traditionally black colleges of medicine, I think we're the first medical school to have that distinction. This current year, and that commitment to diversity continues, 36 different languages are spoken in our freshman class. New York State has more medical schools than any other state in the union. Having said that, a recent study looking at graduates of all schools that are practicing here in New York State, almost 50% of the physicians that are practicing in this state graduated from this school. We consistently rank in the 95th, 96th percentile in terms of the African American graduates, and that again includes the traditionally black schools, so we are graduating more African Americans than virtually any other traditional school in the country. I think that's something we're very proud of. I think it reflects the fact that the students see a commitment to diversity here at Downstate. In fact, in the recent LCME accreditation, we were commended for the commitment to diversity. And I think in a lot of schools, the students come in and they don't see minority faculty. We again rank in the top 10 percentile in the nation in terms of minority faculty. So they see commitment to diversity, both within themselves as a student body and within the faculty. And in fact, in the AAMC data, one of the things that attracts students to come to Downstate is that they see diversity and they value it as an important component of their education. So I do think we're contributing significantly to the physician workforce in this state, and since we are one of the most diverse schools in the country, we are contributing to the diversity of the physician workforce in this state. Having said that, there's still, like we've said with all the other things, we've got a long way to go before the physician workforce reflects the diversity of our nation.
Dr. Duffus, can you tell us from a federal standpoint some of the work that your office is doing to promote diversity in leadership in the public health workforce?
The Centers for Disease Control and Prevention is committed to increasing diversity in the workforce, and we have various fellowship programs. www.cdc.gov, because there are a lot of acronyms: PHAP, PHAP, ORISE, an Epidemic Intelligence Service Officer, EISO, and at all levels of training, undergrad, graduate, postgrad, for summer, for a year, for 2 years, and so on. So Google, look up fellowships and training programs, and it'll all show up. But my office, for fiscal year 2015, got funded to establish a public health leadership training program. It's up $2.5 million, 5 years, at Morehouse School of Medicine and the Morehouse College. One is for undergraduates for a 10-week summer experiential training where kids, half my age, young adults, would come in and learn how to be a professional, be in a professional environment, learn how to write papers, do presentations, and travel. And then there's also a postgrad where you have to have a tertiary degree, and you spend a year doing leadership training, and you'll come to the federal government and do 8 weeks research or policy, and then an additional 8 weeks in a community-based organization, and you'll get to go to Congress, go on the Hill, and do advocacy work. And so we're very committed to diversity in the workforce, and it's something we stand strongly behind.
Well, we want to make sure we leave time for Dr. Duffus's presentation, so I just want to thank the panel again and ask if they would like to give any last remarks or anything that they didn't get a chance to cover. This is a time to do so.
Just one additional thing I just wanted to say. You know, when it comes to addressing health disparities, it's so important that the institution is behind you. And I think the mission, vision, and values of the organization needs to reflect that, because leadership starts at the top. You won't be successful if you're in your little office tackling health disparities by yourself and no one is behind you. And so for the National Center for, well, CDC as a whole, but for my National Center for HIV, viral hepatitis, STD, TB prevention, which from henceforth will be called NCHH-STP. In our mission, vision, and values, addressing health disparities is one of the goals. And I just want to say that publicly, that it's important that you have institutional support for the work you're going to do.
If I could add one additional comment, thank you for the opportunity to just say this, that each of us is here because we believe in the values and the principles that have been discussed today, and we've been reminded of how important these concepts and issues are. We are leaders in our field. We are success stories in our communities and in our families. And certainly as clinicians and educators, we're the most busy people under the sun. But as we leave today, I would hope that you would take something that you've heard today and take it back to your community, to your family, to your friends, to others, because one of the important elements of health equity and the high rates of health disparity is education and awareness of how important it is to remain well while you're healthy, while you're feeling good. and that is more important. I often would say to students, who's caring for the patient on the days that they're not coming to see the provider? They're caring for themselves, and their family members are caring for them. So to the extent that makes sense for you, is it possible to share what you know about health maintenance, preservation of health, health promotion, disease prevention, increasing health literacy among those in your circle? Is there a way that you can attack this big problem of health equity or inequity, basically, by contributing your time, your skills, your knowledge, your expertise at your church, at your synagogue, in your community, where you socialize, in whatever capacity? That's how we break down one by one the challenge or the difficulties that exist within our community. The systems are wonderful, and we're lucky to have them, but it's each one really taking up a part of the responsibility, and so I would just ask you to think about that. Thank you.
Thank you, panel.
So, if I could just say one thing. We're going to have to take up Dr. King's example. We're talking about changing public policies by mobilizing masses of people to make these things happen. And without that, we're not going to be able to achieve health equity. With it, we will achieve it.
Absolutely. And I would simply follow on from that and say political participation is absolutely vital. If political leaders think that people who have a certain amount of money or look a certain way are going to participate or not participate, priorities will reflect that. And I think it's very important that we stop some of these reinforcing cycles when it comes to the social determinants of health particularly, and make sure that everyone gets out there, participates, gets out there and votes. Thank you.
Thank you.
Maybe I can just have one word since everybody else has. Can't be left out. I just wanted to say we will not have a healthy nation unless we can deal with healthcare inequality.
Thank you all.
Wait a minute, panel, before you take your seat. I just wanted to acknowledge your participation here, and so we have little plaques that we want to give out to each panel member for taking out time in your busy schedule to make this happen today. So basically, all the plaques say is State University of New York, Downstate Medical Center, Dr. Martin Luther King Jr. Leadership Award Program, Health Equity Panel, The New Frontier, and Civil Rights. And I want to present these to you now. We'll start with Dr. Beneker. Who's next? Dr. Martin Rios. Sure. Dr. Elke. And Dean Taylor. Dr. Duffus. And of course, to our moderator, Shondell Moore Goldsmith. You got some? So at this time, we want to give out our Dr. Martin Luther King Jr. Leadership Award. The criteria for the award is basically that the recipients, whether you're an individual or an organization, has to demonstrate solutions to societal problems that help America fulfill what it put on paper years ago, that all men, all women, all children, all people who are American citizens are created equal. And at this time, we want to give the 2016 Dr. Martin Luther King Jr. Leadership Award to Dr. Wayne Duffus, his office, the National Center at the Center for Disease Control and Prevention. It's a little silhouette of Dr. King on it. And at this time, Dr. Duffus, as a representative of the Center for Disease Control and Prevention's National Office for HIV, STT, hepatitis, and tuberculosis, he will now give his keynote address.
So, good afternoon. So I have the unenviable task of finishing up. I'm the only thing standing between you and lunch. And I know what that's all about. So I'm going to try to not only educate you, but also entertain you. And I'll keep talking until I get the stop signal, right? Wherever I am, whatever it is, it's going to be important. I should also add that this is so emotional for me because it's like coming back home. I'm Jamaican by birth. And so Brooklyn has a lot of Jamaicans, a lot of Caribbean people. And I also went to Brooklyn College. So it's really coming back full circle. So the invitation here is very much appreciated, and I try not to cry, but thank you for what you do, and it means so much to me. Thank you. All right, so I'm going to talk about how social determinants of health impact health outcomes, health disparities in communicable diseases, HIV, viral hepatitis, STD, and TB, and talk about reducing health disparities and promoting health equity. And so I think it's important to go over the definitions, since I want to be sure that we're all on the same page and we know we're talking about the same things. And so health disparities are differences in the incidence, which is new cases, prevalence is new and old, of health conditions and health status between groups. So disparities are numbers. Not all disparities are unfair. Then there are health inequities, which is the systematic and unjust distribution of social, economic, and environmental conditions needed for health. So for example, unequal access to quality education, healthcare, housing, and so on. In contrast, the health equity, which is the opportunity for everyone to attain his or her full health potential. No one is disadvantaged from achieving this potential because of his or her social position or other social determined circumstances. And here we talk about social determinants of health. Those are the life-enhancing resources whose distribution across populations effectively determines length and quality of life. So food supply, housing, and so on. So simply put, if you have 3 children, different ages, they're all different height, and you decide to take them to a baseball game, and you decide to give them all the same stool. At the end of the day, if they all get the same stool, you end up at the same place. Some can see and some can't. So you really never want to ask for equality. You want to ask for equity. Equity is based on proportional need. If you need more to get to wherever the defined point is, you get more. If you need less, fewer, you get less, right? So always ask for equity. That's where we'll all be at the same level, not equality. So the World Health Organization has a social determinants of health model to understand HIV inequalities, which could be applied to any disease. And you can see some of them here: education, occupation, income, gender, psychosocial factors, behaviors, biologic factors in the healthcare system. I'm going to go through in this presentation some of them, and you've heard a couple of them mentioned. But for the diseases of my center, NCHH, SDP, there's some additional ones that we've put in. So HIV, STI prevalence in your community. So you could be a good girl or a good boy, but because the disease prevalence is so high in your community, you're likely to encounter someone who has the problem and gives it to you. The correctional system is funded for security, not for healthcare. There are more people in corrections proportionally who have higher rates of substance abuse and mental health. They're not a hospital. You're not going to go there for healthcare, even though the health conditions are overrepresented there. We know about migration status. If you're an illegal immigrant, a problem to get in health services. So it's not just America, to be fair. In race-conscious societies such as the ones listed here, the non-dominant racial groups have worse health than the dominant racial group. So let's look at life expectancy for indigenous women. In New Zealand, and these are the indigenous populations here. In New Zealand, life expectancy is 81 in 2004. For everyone else, for the indigenous population, it's 73 years. In the United States, for whites, it's 80 years. For the indigenous population, it's 74 years, a gap of 6 years. Do people think this is big, a big number? All right, don't answer yet. I'm going to show you what it is. Let's look at infant mortality by race. And this is the odds rates for death. And here for blacks, for coloreds, that's what this is called, mixed race in South Africa, Asians and white. For if you're colored, you're 30% less likely to die as an infant compared to blacks. If you're Asian, you're 40% less likely to die as an infant. And if you're white, you're 80% less likely to die compared to a black infant in South Africa. Race and health, there are two patterns. Racial groups with a long history characterized by economic exploitation, social stigmatization, and geographic marginalization have markedly elevated levels of poor health outcomes. Also, immigrant groups, and this is important to me since I'm one of them, immigrant groups tend to have better health than the US average, but their health tends to worsen over time and across subsequent generations. So let's look at lifetime prevalence of psychiatric disorder as an example of this by race and generational status. For Caribbean Black, Latino, and Asian. First generation, so like myself. Second generation, my children. Third generation, my children's children. If you notice that the prevalence of psychiatric disorder increases across subsequent generations for Caribbean Black. The same for Latino, and even the same for Asian. It appears there's something about living in America that drives us crazy. So let's look at life expectancy. So people are living longer. No matter how much we criticize our hospitals and our hospital systems, people have lived longer. If you look at whites, for example, in 1950, the average lifespan here was like 69.1 years. If you look in 2010, it's now 78, 79 years for whites. Same for blacks. In 1950, it was like 61 years. And in 2010, it's now 75 years. It's a gap of about 4 years. Is that a big difference? Show me a raise of hands if you think that's a big difference, if 4 years is a big difference. It's a huge difference. You know why? Because the last time with whites were 75 years life expectancy was 1980. 30 years. It took 30 years to close that gap. All right? So even a 4-year difference is a humongous difference. It took a generation to get to that point. So there are large racial ethnic differences in socioeconomic status. Higher income, longer life. Ask for more money. Adult life expectancy increases with increasing income. Men and women in the highest income group can expect to live 6.5 years longer than poor men and poor women. Ask for a raise. All right? Even if you're within a racial ethnic category, a rich black person lives longer than a poor black person. A rich white person lives longer than a poor white person. Ask for money. So if that's true, let's look at median household income by race in 2013. Racial differences in income are substantial. For every dollar a white person makes, Asian makes $1.15. Hispanics make 70 cents, and blacks make 59 cents. So if income correlates with health, right away, you see a problem. Now let's look at wealth, everything that you own. So for every dollar of wealth that whites have, Asians have 81 cents. Blacks, you have 6 cents. Latinos, you have 7 cents. I just told you that income and wealth is important for health outcomes. That's a problem right here. So racial ethnic disparities in health is more than socioeconomic status. We think everyone is going to college. Not true. Everyone here might have, right? But for the United States, for whites, according to Census 2010, only about 31% of whites, blacks 18%, Asians 50%, Hispanic any 13%, Pacific Islanders 15%, American Indian, Native Alaskan 13%. Not everyone is getting education. And I'm telling you that education is important to have a good health outcome. So more education means longer life. For both men and women, college graduates can expect to live at least 5 years longer than individuals who did not finish high school. So if you have any educational thing pending, go do it. All right? That's the second lesson. So life expectancy at age 25, how long do you think you're likely to live past 25? So for all, we know that there are black-white differences, that there's a gap. White individuals live longer than black individuals. We know that. I just showed you about life expectancy, right? I also told you that education is important. So even within racial groups, if you're white and you have education between 0 to 12 years, you're going to live a shorter period than someone who's white, who's a college grad, a difference of about 6 years. Ask for money and get an education. The same if you're black. If you have 0 to 12 years of education, you expect to live 47 years, predicted at age 25. And if you have a college degree, 52 years, a difference of 5 years within that group. All right? But notice something, that if you're black and have a comparable educational level as someone white, you are expected to live a shorter period. You're essentially not equal in terms of your health outcomes, which suggests that there's something else going on besides education and income. So I'm a doctor, and I figure, hey, I have a lot of school. I mean, half my life seems to have been in school. So maybe I'm going to live forever, I hope. So there was a study where they looked at a cohort of Meharry Medical College graduates who graduated between 1958 and 1965, and compared that with a white cohort from Johns Hopkins, 23 to 25 years later, to look at differences. Doctors who went to a historical black college and doctors who went to Johns Hopkins, who were white. The black doctors had higher risk of cardiovascular disease, earlier onset of disease, incidence rates of diabetes and hypertension that were twice as high, higher incidence of coronary artery disease, and higher case fatality rate, even among a highly educated population. Why does race still matter? Could racism be a critical missing piece of the puzzle to understand the pattern of racial disparities in health? Despite enormous progress in race, there are ubiquitous signs of the pervasiveness of racism in our culture. There is something called individuation, and now patients will tell you this. When the patient walks into the room, we just label them, right? There they go again, that drug user, that welfare recipient, that this, that. Instead of looking at across populations and treat each person as an individual, right? And then the patient never comes back to the doctor's office, and we wonder, why won't they come back? We blame the patient and not the image we put forward. So there's institutional discrimination can restrict socioeconomic attainment and group differences. Segregation can create pathogenic residential conditions. Discrimination can lead to reduced access to desirable goods and services. Internalized racism, the acceptance of society's negative characterization, can adversely affect health. Racism can create conditions that increase exposure to traditional stressors, and experiences of discrimination may be a neglected psychosocial stressor. So residential segregation, where you live, matters. Geographic location determines exposure to risk factors and resources that affect health. So it's not everywhere in Brooklyn has a problem, right? You know the communities, right? It's not everywhere in New York City has a problem. It's certain neighborhoods. And guess who lives in those neighborhoods? So residential segregation is a place-based example of institutional discrimination that has pervasive adverse effects on health. So racial segregation is basic to understanding racial inequality in America. It's key to understanding racial inequality. It's the linchpin of US race relations and the source of the large and growing racial inequality in socioeconomic status. It is one of the most successful political ideologies of the last century and a dominant system of racial regulation and control, and is the key structural factor for the perpetuation of black poverty in the US and the missing link in the efforts to understand urban poverty. So how does segregation affect health? It determines the quality of education and employment opportunities. How many hospitals are there in Brooklyn compared to Manhattan? Segregation can create pathogenic neighborhood and housing conditions. How many luxury high-rise condos there are in Brooklyn? Conditions linked to segregation can constrain the practice of health behaviors and encourage unhealthy ones. We say to someone, you should get 30 minutes of exercise every day or 3 times a week. We're the jogging path, right? Or if you go jogging, is a car gonna run over you? Or if you're in South Carolina, maybe you get shot, right? Running through that park, right? Segregation can adversely affect access to high quality medical care. If you live in a community where there's no hospitals, you can't get care. In the 171 largest cities in the US, there's not even one city where whites live in ecological equality to blacks in terms of poverty rates or rates of single-parent households. The worst urban context in which whites reside is considerably better than the average context of black communities. Economic policy is health policy. In the last 60 years, black-white differences in health have narrowed and widened with black-white differences in income. Essentially, for what this says, when a man or a woman grows up to be a commercial sex worker, or an individual becomes homeless, no one grows up wanting to be homeless or be a commercial sex worker. Something happened. Society failed. There's something we did not do the day before, right? It's like you become HIV positive and then you have all these services. Food and nutrition services, you get housing, you know, you get a car, you get a car, you get a car, you get a car, right? What happened to the day before you got infected and became positive? What did we not do to help that person? But if you empower the individual, and this is what the slide is saying, give the person a job, they'd rather that. They'd rather go work and make money than be a prostitute and sell drugs and all those other stuff, all right? Something to keep in mind. So the health effects of civil rights, policies narrowed black and white, the economic gap. The gains were greater for women than men. Black women had larger gains in life expectancy during 1965 and 1974 than other groups. Between 1968 and 1978, black males and females aged 35 to 74 had larger absolute and relative declines in mortality than whites. Black women born between 1967 and 69 had lower risk factor rates as adults and were less likely to have infants with low birth weight and low APGAR scores than those born between 1961 and 63. And desegregation of southern hospitals enabled 5,000 to 7,000 additional black babies to survive infancy between 1965 to 1975. That is what ACA is also trying to do. So, shifting focus, and time is going, but I'm going to keep talking. Talk about the health disparities in HIV, viral hepatitis, STDs, and TB. Race and ethnicity. African Americans are 8 times, and Latinos are 3 times more likely to have HIV than whites. In 2013, African Americans had 12 times the reported gonorrhea rates of whites. Asian and Pacific Islanders make up less than 5% of the total US population, but account for more than 50% of Americans living with chronic hepatitis B. In 2014, Asians had the highest TB case rate, which was nearly 30 times higher than the case rates for whites and 3 times higher for those of African Americans or Hispanics. Gay, bisexual, and other men who have sex with men account for 63% of new HIV infections and are the only group in which HIV incidence is rising. They are 40 times more likely to have HIV or syphilis than any other men and account for 15 to 25% of all new hepatitis B infections. For LGBT youth, they have increased health risk behaviors, so injury, violence, suicide, tobacco, alcohol, sexual behavior, diet, physical activity. Lifetime risk of HIV infection among men who have sex with men. If current trends continue, half of today's young black men who have sex with men will have HIV by age 35. Half of all men who have sex with men will have HIV by age 50 if current rates continue. Where you live matters. Geography is important. 46% of all adults and adolescents with HIV live in 4 states: California, Texas, Florida, and New York. 9 states and Washington, D.C. reported a TB case rate above 3 per 100,000 population. These areas accounted for 57% of the national total. Where you live affects the health you get, the health care you get. Age. If you're young like me, and you're between 15 and 24 times 2, make up 27% of sexually active population, but 50% of the 20 million new sexually transmitted infections in the US. 1 in 4 new HIV infection occurs in youth aged 13 to 24. About 12,000 youth in 2010 were infected with HIV, and more than 75% of adults with hepatitis C are baby boomers, born between 1945 and 1965. Socioeconomic. If you look at socioeconomic status, it removes racial ethnic difference. HIV is not a problem of black people, right? It's a problem of poor people. The poorer you are, the more likely you are to be HIV infected. The more money you make, the less likely you are. The racial ethnic differences disappear based on income. So reducing health disparities and promoting health equity. So I referred to on the panel about the health impact pyramid. If you go down the pyramid, less individual effort. If you go up the pyramid, more individual effort. Things that affect the general population, I told you how education is important. You want more school. Education, housing, transportation, business affects everyone and gives a better health outcome. Changing the context to make individuals' default decisions healthy. If you go to school and the only thing on the menu is healthy lunch, you have no choice but to eat healthy, that fruit salad. But if you give me a fruit salad and you give me a hot dog and pizza, which one you think, if I'm 6, 7 years old, I'm going to eat? Right? I'm going to go for the pizza and the hot dog. Right? And when I go in here and eat lunch, guess what I'm going to go for? Because you put it in front of me. But if there's only a salad, I have no choice. But if you change the context, right? Long-lasting protective interventions require some effort. You have to go to the doctor to get a vaccine. But once you get the vaccine, you're good, right? Clinical interventions require more effort. And they're often done for things you can't even feel. So somebody tells me, hey, you have high blood pressure, you have high cholesterol. Take this pill every day for the rest of your life. Really? Right? How often, how compliant am I? Requires a lot of effort. We spend a lot of time doing education and counseling. We talk. And we think we say something to the patient. We see them every 6 months and they're supposed, because we're God, we say it and you're supposed to do it for the next 6 months until you come back and see me. And then we go, well, why don't you do what I told you to? Right? I say use a condom all the time. Each and every sexual act. But when I go home and I watch TV, it's like softcore porn every day, right? I tell you to eat healthy diets, and I watch TV and it tells me to supersize everything I eat, right? So we spend a lot of time on counseling and education. It's not that they don't serve a purpose. We don't do them frequent enough. The content of what we talk about is questionable at times, and it requires a lot of individual effort. So redefining health, 60 to 70% of health has seemingly nothing to do with health. We need to look at housing, employment, community development policies, income support, transportation, environment. So when we have meetings in these hospitals, people from those institutions should also be at the table. If I just tell you those things are important, oftentimes they're not there. And so you come back 10 years, you know, a mentor once told me when I just started off as a young professional, and he looked at my face and I was totally confused. And he said, don't worry about it. Come back 10 years, we'll be talking about the same things. True, because we really haven't addressed the root cause of the causes. So improving health, enhancing neighborhood and housing quality to improve health is important. So I'm in the National Center, my office is here. We have 5 divisions: HIV/AIDS prevention, STD, Division of Adolescent School Health, Division of HIV/AIDS prevention, Division of TB elimination, and the 3 of them have offices of health equity, and we contribute members to a health equity work group. We meet monthly, and we talk about research, policy, and programs that affect the nation. There are additional work groups that we participate in, and they're listed here. So, addressing health disparities is part of our national strategy. It has to be at the highest level of government for it to be important, right? It has to be there for leadership. Also, money has to follow it. You know, I know something is important to you is how much money you put towards the problem. Because you could say it, but here's $2. What am I going to do, right? Put money where it is. So it's in our strategic plan. Here's the goal. 1 is to decrease incidence of HIV, decrease incidence of infection, decrease morbidity and mortality, and decrease health disparities. It's a multi-tiered approach. Basic fundamental knowledge for all Americans, accurate information about HIV and sexually transmitted infections, for example. There's also community level and structural approaches in hardest hit geographic areas and populations, so widespread condom availability, social marketing for behavior change to foster supportive community norms, and then finally intensive individual interventions for those most at risk. So we talk about combination prevention. We're sort of done away with that. That's like doing everything, right? We say no, because combining interventions is not enough. All interventions are not effective. all effective interventions are not equal. So we've transitioned from combination prevention to something called high impact prevention, targeted and focused. So we've developed some metrics, and I've listed some of them here because, oftentimes you come to work and you feel you're doing so much, but when you come back tomorrow, the problem is still there. So you're really effective at what you're doing? You know what I'm talking about, right? We've been doing this struggle for a very long time, and how far have we advanced? So it's important to measure what you're doing so you can make changes as you move along. So the next list of slides is some of the things that the agency is doing. So Health Department prevention funding, we have matching prevention funds to the HIV epidemic, about $360 million awarded to 68 health departments based on HIV prevalence. Geography is important, allows flexibility based on local epidemic modeling and needs, requires health departments to focus on interventions that will have the greatest impact on the epidemic, and jurisdictions must spend 75% of their budget on 4 key strategies through HIV testing, policy and structural interventions, and condom distribution. The expanded testing initiative, $102 million over 3 years, 25 jurisdictions. There were 2.8 million people were tested. About 18,400 persons were newly diagnosed with HIV. 70% were African American, 12% Latino. 3,381 HIV infections were averted. Recent funding awards targeting high-risk persons. New funding opportunity announcement will provide $185 million over 3 years for men who have sex with men and transgender persons, up to $125 million for health departments to increase PrEP. That's HIV pre-exposure prophylaxis to help prevent HIV infection, and using surveillance data to increase engagement in care. When patients come to the clinic or the hospital, we collect all this information. We seemingly lock it into a vault and nobody ever sees it. We need to look at our data and ask questions and address the issues that come up. We have a lot of public health campaigns. You've all been on the buses and on the trains, and we have posters, brochures, pamphlets, Act Against AIDS Leadership Initiative. It's important to keep the message in. People need to know that there is a problem. The squeaky wheel gets the most grease. So that's important to have those campaigns. The hepatitis B campaign, 1 out of 12 Asian Americans and Pacific Islanders has hepatitis B infection, and an estimated 2/3 do not know they're infected. There's the No More Hepatitis B campaign launched in 2013, and it's the first national multilingual, multi-year hepatitis B communications campaign aimed at Asian Americans and Pacific Islanders. We're boosting hepatitis B prevention funding, awarded to 32 organizations to expand testing for hepatitis B and C, and linkage to care, treatment, and prevention. It includes funds for testing those at higher risk for hepatitis B and linking to care. Addressing TB inequities. So TB is a problem in 2 groups. We've done really well at almost eliminating TB. TB is a problem in homeless populations and foreign-born populations. So we need to increase our services for those 2 groups. And Brooklyn has a lot of foreign-born folks. Keep that in mind. CAPAS, Care and Prevention in the United States, $45 million over 3 years. Eligibility for funding limited to 18 states with the highest HIV burden. Among African Americans and Latinos and high AIDS diagnosis rates, you see the states. The focus on original ethnic minorities with HIV, with increased proportion diagnosed, overcome social and economic obstacles, social determinants of health, and work towards suppressed viral load for all. Don't forget about the schools. Everything starts with education. So the Division of Adolescent School Health has a funding opportunity announcement aimed at states with the highest HIV burden and local school districts based on HIV STD burden, poverty level, and number of students. The funding opportunity announcement includes prevention for young men who have sex with men. School districts encouraged to provide safe and supportive environment for LGBT youth, and health risks measured via the Youth Risk Behavior Survey. So the last thing about what we do, STDs, the STD prevention funding opportunity announcement offers greater flexibility to programs to direct resources to areas based on local needs. And something we're particularly proud of is the development of an HIV/STI curriculum for historically Black colleges and universities for medical schools. Doctors really suck at taking a sexual history. Right? Nurses are way better. We're uncomfortable, very uncomfortable. And medical school teach you about the disease, but they don't teach you about how to talk to people about very sensitive issues. So we're hoping to do better at that by development of this curriculum. So we have a lot of documents. We release policy documents about how to achieve health equity. We have a white paper commitments about the things that we're going to do, and I'm going quickly because I know lunch is sitting out there. We have a lot of consultations where we bring really smart people like yourself to the agency and ask you, what are we doing right, what are we doing wrong, where should we go and move forward. More policy documents, the public health reports, 3 special issues that talk about social determinants of health, and substantial health disparities with HIV, viral hepatitis, STDs, and TB. Reducing disparities and promoting health equity is a top explicit goal for NCHHSDP. There's need for specific indicators and targets. We need more partnerships, workforce developments, and champions, and maximizing reductions in disparities requires careful modeling, targeting distribution of resources, and thoughtful individual, community, and societal level interventions. Thank you, and thank the patients, those infected and affected. Thank you for this invitation and all the gifts that I got in the lunch I'm supposed to eat. Of course, I would thank my agency with my work for to help my fellow citizens, the fellow panelists, and Dr. David Williams, who's a sociologist at Harvard. Many of the introductory slides that I gave are his, essentially, and thank you so much.
That concludes our 2016 Dr. Martin Luther King Jr. Leadership Award. We want to thank Dr. Duffus again for accepting the award and coming all the way up from the CDC. Thank our panel members. Thank the Vice Chancellor for coming all the way down to Albany to give us some greetings.